Doing great. We had a great start with Dr. Weng Chu and all the way from Singapore and Milio in the middle of Indian Ocean. And now we're up in New York.
Well, you know something? Let's do it. I'm going to push the share screen. And let me ask you, can I record this as I'm doing it or no?
Absolutely.
I mean, yes, you can, but be careful. I don't know. Honestly, let me ask this question to
but this also will be recorded anyway, and it's going to be
available
shortly after.
Oh, you're going to record me? You mean I have to listen to myself twice?
You're on the record.
Yeah, I'm afraid that if you try to record simultaneously that we're transmitting, can delay something. I don't know. So I'm asking the technical guy to see if that can create a conflict. Anyways, are you ready?
Anyway,
I am definitely ready.
Okay, so 3, 2, 1, go!
All righty. So today's lecture is called Pattern Recognition, and it's predicated. And I got to go back. Okay, let's escape this and click here and get this thing going. Okay, so what I'm going to talk about is I'm going to put my things into perspective from what I have with my interview. And 4-sector diagnosis is simply a workflow program that I use. I developed it. And I'm going to talk about the diseases which are hiding in plain sight. And they do repeat themselves. So I produced some icons for you so that you can understand exactly what I'm going to be talking about. I'm going to be talking about the hard tissue joint shapes that you can see on an MRI that are associated with diseases, and they're repeatable. So you can find them relatively often. I think there are a couple of things that need to be established first, however. One of the things that you're going to see that binds all the cases that I have together, number one, is thyroid disorders. Most of the time, it's autoimmune thyroid disorder. Most of my patients have Hashimoto's disease. Number two, with the exception of one photographic imaging study, you're going to see that all of these are women. So whether or not there's sexual dimorphism between men and women in showing you these diseases is something that I can't establish at the present time. And so my pictures are the wrench end, which is associated with hypothyroidism and Hashimoto's. I do not have a Graves' thyroid case to show you. I'm going to show you the spondyloarthropathies, and I picked the belly of the seahorse along with the beak of the pelican, which I call a pelican profile. The other in rheumatoid arthritis is the inclined plane. And in celiac disease, I use the bent branch. And as I come down into the most aggressive form of the osteoarthritic diseases, it's erosive arthritis. I'll show you one case with that, which has a sawtooth appearance and somewhat of a gull wing edges to it. So I'm going to show you the blood test with everything except erosive arthritis. And I'm going to show you two videos. I want you to see what the fibrotic tissue looks like on the inside of these joints when they go in there to do an arthroscopy. And I don't recommend arthroscopy for everyone, but one of the things that's coming out of this whole thing is that by pairing my blood tests to the images, I've been able to train myself to see the subtleties that we overlook because we don't really know any better without the trained eye. And you just glance over these things and you say, okay, they've got degenerative joint disease. Now, the important thing to remember here is that when I order an imaging study, a lot of what I see is on the sagittal slices. And I'm used to looking at sagittal slices when they're perpendicular to the long axis in the mediolateral direction. So if you don't order them, and this is what happened, I became very friendly very quickly with Lucas Lossman, and we've been on FaceTime all the time, and he sent me a case by MRI. He said, can you help me with this? And all of a sudden I was confronted by the fact that he had these sagittals in the oblique cuts, and I couldn't get as much information because I just don't see it like that. So that was difficult for me. Still, I'm hoping to be able to guide him as we're talking through this case. So in 4-sector diagnosis, my workflow is very simple. I want to get all the information I can up front from the history. This is an 18-page questionnaire. It is very detailed, and it helps me to begin to think about what diseases this patient may have and how I'm going to order my blood tests. I also ask if they've had previous imaging studies done. I want to see them in advance, and of course, I don't get to examine them until they walk in the office. Now, all these things are going to provide me with information. In my imaging studies, I am traditionally doing MRI. The panaural will generally come along at some point in time. If I think I need a CT or the patient's had a 3D, I certainly want to see those. But even something as simple, if you're a pedodontist or you're an orthodontist, something as simple as a lateral ceph, where you take a look at this and you can see that the inferior borders of the mandible have a differential in height to them, that can be a real tip-off for you in picking up the fact that this patient has some sort of joint disorder. So what I do now is I convert the logo into a target area, and I look for the diseases. And if I can find a disease, then I can get that patient medically optimized. Don't be fooled by medical optimization. If a patient has a disease, you're not going to reverse it all that quickly. And you're going to see Hashimoto's in here, and you're going to see celiac as two fine examples of that even if you put a patient on a gluten-free diet, the chances are you're not going to reverse the damage that's already been done. What you may do is slow down the progression or stop the progression. The fact that they're on a synthroid type medication, levothyroxine, doesn't mean that you're curing the Hashimoto's or thyroid disorder. It simply means you're trying to provide a way to control it, and you're going to see what the damage looks like. Now, what I was doing in the very beginning is I would get all this information, run the blood tests, and I was doing good guessing, and then I was comparing it to the imaging studies to see if I could find what the common denominators are between diseases. Now what's happened is I flipped the tables. Now I can get my imaging study first because I can pare down what I'm looking for. I can't do it for everything, but now this, okay, is the box that I brought alive to be able to tell me what to run, at least in the preliminary stages, so that I'm not offering tons of blood and throwing out a wide net, although that still happens sometimes because there are things that I still don't identify on the imaging studies. So in my questionnaire, I have 33 categories. I call this the DAIS, okay, Diagnostic Axis Indicator System. This is a guidance system for me. This is my front page, and this is where I put all my notes. There are 33 categories where I will ask the patient what type of disorders. I quickly check them off so I have an idea of how I'm going to put the story together for them. And here's the first case. This is really as close as I can get to a full case with you without blowing away all the time that I have in the 30 minutes. But this is a middle-aged white female. She comes from the northwest area of the country. And she has a left side open bite and an anterior open bite. You can see she does make some contact with the right side. And you can start thinking about this even if you take a panoramic X-ray. So you could see that the distance on the occlusal measurements over here, the space on the left side is open, correlates nicely with this. Of course, she's on a bite block a little bit, you know, while she's taking the image, but you can see how this image all of a sudden reflects the photographic pictures that you would take. Now, if you take a look at this, and this isn't the greatest panoramic, but I'm already starting to think, here's my inclined plane on the right side. And when I think about inclined planes, the first thing I think about is RA. So there's a chance that if you see an inclined plane, that it could be rheumatoid arthritis. It's not an absolute. And I'm starting to think about what disorders start to mimic RA on interpretation of imaging studies. So I think that this is one of the parts that's not absolute, but if it brings me to 25 to 75%, I know that's a big spread in there, at least it gives me something to track off of. And then you can take a look at the left joint and you can start to see there's a little deformity, the little divots that you could see around here, the kind of shape and slope of these things. Take a look at the slope of these things and you're going to see even more on the imaging studies. And so in her history, it's important for me to start to pick up on symptoms as I'm putting the story together. And I can't go over everything, but what I knew coming in is she had hypothyroid disease and she had the RA. Those blood studies were already done. She's under the care of her physician and her rheumatologist. And she talks about her headaches and the vertigo and the other things. And right away, I see the lower back pain and she has painful sex. And I'm thinking right away, okay, I'm in the reactive arthritis spondyloarthropathy area. And you start to take a look at the CT scans that she sent along with her profile, and you start to carve out, like from Mount Rushmore, this image. And when you take a look at the image, I want you to see this pelican profile beak. Here I have my seahorse belly. When I look at the beak, I don't think osteophytes, even though you could call it that. What I do think is depositional bone deposit. I think about bone growth, because what I want to do is I want to expand the category. The last thing that I want to do is paint myself into a corner. Leave myself with the category as big as I can, because there are other things that can cause bone deposition. One of the places you can catch it is in small cell lung carcinoma. You can call it hypertrophic osteoarthropathy. There are lots of things that you can put into this thing, so don't pigeonhole yourself. That's a mistake. Leave your opportunities as wide open as you can get them. And here you can see on the MRI, now you'll notice there's this little U-shaped deformity that you see in the cortical bone. Here you see it on the MRI. This is what it looks like on outline. And you're going to see it over and over again today. Here is the slope. So when I put these things together, okay, here's my potential rheumatoid arthritis. Here's my thyroid disorder. Here's my wrench. I won't put the triangular block in there. Okay, and if I'm doing blood tests, here are the tests that I would order. Generally speaking, I want a CBC with a differential in platelets. And in this particular lab, I'm going to take a look at my immune cells, at least a preliminary look. There's plenty to look at in immune cells, but this is a start, okay? And I want a metabolic panel. And from that, I'm going to be able to see if there are any organic problems that I can further my exploration with. I'm going to check for the rheumatoid arthritis. This is one of the ways that you can do it. So you want not only your rheumatoid factor, but you want what's called CCP, cyclic citrullonated antibodies or peptidases. So that's how you pick that up. And then there are other tests that you can add to diagnosing rheumatoid arthritis. And here's how I do the thyroid panel. So as I'm going through this, I'm always thinking, what am I going to order? Now, this is specific for Hashimoto's, the thyroid globulin antibodies and a thyroperoxidase. But there are ones for Graves' disease, and you should know to look through them. Now, when I take a look at her from the axial view, you notice what I've got going on over here. I've got 2 areas of bone deposition. So this is not just a degenerative change. This is not just destructive. There's an additive component to this. And I'm going to pick up my seahorse belly, and I assign that at the present time to the Crohn's category. I'm still in the spondyloarthropathies, and there are 5 components to the spondyloarthropathies. And I think a little homework on your part will take you a long way. But what I want to do is I want to solidify this whole thing. The blood tests you order for this are HLA-B27. HLA stands for human leukocyte antibodies. It ties with what's called, as part of your immune system, the major histocompatibility complex. Now, not everybody with HLA-B27 is going to have a disease. Only 14% of the people with HLA-B27 are going to be in the spondyloarthropathy category. But if they have a spondyloarthropathy category disease, 90% of them will have the HLA-B27. So there's a difference. And when you're looking for Crohn's disease, you're looking at the primary test that's in the blood. Of course, this should be confirmed with an endoscopy, is Saccharomyces cerevisiae antibodies. So that's how I pick this stuff up. Notice that what I'm looking at is asymmetrical component. And that's a big thing because the spondyloarthropathy category has many different subtypes. And to be familiar with the different subtypes, whether it's axial or peripheral, whether there's specificity in site localization, all these things add to the diagnostic intuitiveness that I've developed in putting these things together. So they don't all look the same, and you should know that all of these diseases are heterogeneous in nature. And so there are lots of different categories. So even if I get a case, this is a different patient who has an open bite on her right side, you can see that on her right, there's a depositional bone disease. You can see the likeness to a seahorse belly, and then you start to carve out. Not all of these will be exactly the same. This could be a condylar hyperplasia case. I don't know yet. But this is how you start to think about this, and I posted an article down here that you can take a look at in relationship of rheumatologic disorders and what the inflammatory bowel diseases bring to joint disorders. Now, in this particular patient, she was positive for the Saccharomyces cerevisiae antibodies, and that may tie her to the Crohn's disease category. So she had an endoscopy. She doesn't have Crohn's at the present time, but you have to keep the positive predictive value on the table. And when you take a look at the literature with these antibodies, the PPV, as it's called, positive predictive value, would demonstrate that, at least with these articles, within 36 to 38 months, she may develop Crohn's disease. And then you bring to the table the chlamydia grouping, and this is chlamydia pneumonia, trachomatis, which is the STD, and Sitachi. I have found all of these in patients. And now they're talking about chlamydia pneumonia, which is not the STD, which is coming from the lungs predominantly as a trigger for the infectious reactive arthritis. All these things are still on the table. The rheumatoid arthritis has several candidate organisms. The most common is Mycoplasma pneumonia, or you could take a look at Prevotella mirabilis. Those are 2 of the common ones, but not the only ones. And here's how I order the chlamydia profile. I want all 3 of these in my blood study. I don't want to keep having to send the patient back with just a chlamydia group, which doesn't tell me specifically which one. One of the things that you should know about is that if you're a paleontologist and you're out looking for fossil remains and you find one bowl as you're looking through the soil and you take that bone and you're saying, my goodness, I'm hoping I find the rest of the body here because I like to find a complete skeleton. Autoimmunity is the same way. Polyautoimmunity or multiple autoimmune disease are the norms. They are not the exceptions. So you can expect that multiple ones will come about. So we're going to move away from that case, and this is the only male in the group. He is a friend of the family. He's the son of two of our closest friends. And he doesn't mind if I use his name, not his full name. So this is James. So James came to me when he was 15 years old. And what I knew about James at the time, you can see the date, it's 2007. I'm not even at the point where I'm running most of my own blood tests at this point. I haven't grown that much yet. You can see that there's this little divot there. So this is the T1 sagittal closed view. And I'm out on the lateral pole of this because you can see the external auditory meatus. And when I take a look at this, you can see even more clearly in 2007, he's got this. And in 2009, he also now has on the T1 weighted image, this bright spot over here with a little divot or the U-shaped form. Now, I have to separate out that bright spot because this is a great case for me. This is a case, you're listening, Hamid?
I'm here. I'm here.
You're listening. This is the case,
yes.
Idiopathic Thrombocytopenic Purpura. Okay. There are a lot of soft tissue subtleties in this particular case that I cannot now recognize on the T2 image, where you see the synovium over here is very dark. And that's characteristic, not of ITP per se, but hemophilia cases. So when you think of a reduced platelet count, you can start thinking about this as bleeding disorders in the joint. So that's how I look at it. So when you're bright on T1 and bright on T2, that's a fat replacement process. He goes now into the pattern recognition file in a holding pattern. This is what you have. You take your unusual cases and you catalog them so that you can pick it up for the next patient. Now, of course, James did have Hashimoto's disease, which I failed to mention, I think. This is a good case. This is a case in progress right now. If you take a look, she's got the thyroid disorder. Whether or not she had Hashimoto's, I don't know, but she progressed to thyroid cancer. You see the U-shaped or even deeper V-shaped form. And here I have this cobblestone appearance to what either appears to be a synovial chondromatosis or synovial cyst. Now, here's a case where this woman can't open much more than between 17 and 25 millimeters. She's been to a couple of surgical consults. She's waiting for the third one, who's going to get the biopsy. She's caught up in the COVID. She can't get to where she needs to get at this particular point in time. But certainly the doctors have taken a look at this. And the preliminary one is the question mark of the synovial chondromatosis. Now, you have to consider, if you don't get the imaging study on these cases, what are you going to do with an appliance on this? What are you going to do with equilibration? She is locked down. So this is a surgical case in one form or another, whether it's going to be an arthroscopy or an open case. I don't know what the surgeon wants to do yet, but we'll let them sort that out. And hopefully I will learn something about what she has as a result of the biopsy. These are the two cases that you're going to see now that have the videos associated with them. Both of these are Hashimoto cases. The one to your far left, here's my wrench. Okay, she also has Lyme disease that I picked up. And when you take a look at her profile, this was done, I think, maybe back in 2011. I got lucky with the Lyme disease on her. I picked up the rash. It wasn't a typical target type pattern, and I got lucky. She didn't want me to do very much over here, but she did end up going for an arthroscopy. And you take a look at all of the patterns that you see in the wrench. What you'll notice on the other patient, so it's separate from this woman over here, She also didn't want further testing. She had the Hashimoto's. Look at the size of these effusions that I have. Whether you go forward or backward, whether you do an equilibration on this, the chances of you finding a real comfortable spot for her, because it occupies both the anterior, posterior, and superior dimensions at one point, is going to be very difficult. So let's get going over here. This is the first woman with the combination Lyme disease. You're looking at the synovitis, and as they're pushing that back, okay, with this little hook-like device, so I think of it as a crochet hook, and then you'll see the rotary device come in. Look at all this fibrotic tissue that's in these joints. It looks
Sorry,
like candy.
3 minutes.
3 minutes left?
Yes.
Okay. Okay.
Sorry.
That's okay. I was from 8:10 to 8:40. It's only 8:30.
I will check right now. Keep going for now, my friend.
Okay. And here you see what they do is after they clean this out, remember he's in this superior space, and then we'll take a look at the other one. Now, what I want you to see is that as he's doing this, and this is Dr. Howard Israel's work, in that fibrotic tissue, you're going to pop into these vacuous holes where the fluid lies. So I think it's important to appreciate how the disc is pushed out of the way by the accumulation of this fibrotic tissue and fluid dynamics. And there you see that big hole, and you see the bleeding that often is concurrent with this. Okay, so let's move forward.
Larry, you're right. I'm sorry, my bad. Keep going.
That's okay. Now that I'm rushing my tail off. Okay. All righty. This is one of the most rewarding categories that I have. This is the celiac combination Hashimoto's disease category. Now, whether or not there are other diseases, this woman with the SC, that's the initial, so I know who they are. She did have an issue where she had anti-smooth muscle antibodies, which is characteristic of autoimmune hepatitis. So that came and went. It was transient liver disorders associated with abnormal liver enzymes, etc. But I was kind of surprised by this one. First off, when you look at a joint on an imaging study, it is so easy. Okay, they've got degenerative changes, and then you just roll on by. And you'll see the effusions and the soft tissue abnormalities, and you don't think about it. When you actually take a look at the form, it looks like this bent branch. And yes, at the ends over here, you'll see they have the U-shaped thing. Sometimes you have to come out to the lateral pole, but they're on the medial also. And then I picked up this second case. I said, I know that shape. And I went right to the first one, opened up her imaging thing. I said, holy cow, they're like twins. I couldn't believe it. And then when I was looking through the study, now this is Louis McCurry's study. He calls this condylar resorption, okay? Doesn't have the disease. But I want you to take a look at this. Number one is, here's the posterior band. It's ballooned out, it's pulled all the way forward, and it's almost, look at the size of the effusion on this, and look at what I've got in the patient above him. It's almost an exact clone of what we're looking. So these particular shape patterns do repeat themselves, and you see them. Now, whether or not this is pathognomonic for a male, I can't tell you. I don't have any males in my practice with celiac that have TM joint disorders, but you can see the typical U-shaped wrench pattern associated with the Hashimoto's. And you'll see that the branch thins towards the top as it's going into the fossa. And these things can have such an abundance of fibrotic and retrodiscal tissue in there that they distract the joint downward. And so it's not unusual to see a unilateral open bite on one side. Okay, but if there's been enough bone loss, you may end up with kind of like a compensatory agreement where you might not see any direct occlusal changes in the earlier stages from when the patient notices this. Important to recognize, 21% of the people with celiac disease are asymptomatic. Here are the tests that you could use for this. This is taken from LabCorp. I tend to prefer them over Quest for this. They give me more options. So I tend to stick with the basic one up top. But there are people that who have gluten sensitivity that don't have celiac disease. So they're non-celiac disease gluten sensitivity cases, and they can look very similar to this category. Now, here's the last case. She's very complicated. I'm still sorting this out. And this is a case of what I'm at least calling erosive aggressive osteoarthritis. Notice the sawtooth appearance and somewhat of a gull-wing shape. This is described in the literature on the fingers, on the phalanges, as very common presentation. I transferred it over to here. Now, one thing you find out about osteoarthritis is that there is a rich association with mast cells in this category. And this woman may have what's called common variable immune deficiency. She's got immune deficiency. She now gets over 4 chronic upper respiratory type infections per year. If she travels, she gets sick when she comes home a few days later. Very characteristic. So here are the groupings, at least for the hard tissues. There are cases with soft tissues that I'm able to identify and categorize the people. And I think it's important because what I'm starting to do is to be able to match what I find to treatment and treatment outcomes. And I think this is important because it now becomes data-based. Do I ever have enough blood? Do I ever have enough support? I think that that is a real question. I think this needs to be validated. There are gradients between your environment and what diseases could be common in that environment. There are east-west gradients within the United States. Certainly other countries have east-west, north-south gradients as to the kind of the disease and the prevalence of the diseases. So that's important to pick up. And here we are at the end. You know something? This has been a remarkable journey for me to get my head out of this funk where you look at something and you have this blank expression on your face. What is it? But once someone points these things out to you, no one pointed these out to me. It was just banging my head against the wall, continuing to look, but it has now become a diagnostic tool. And they said that very same thing in a book I have written in 1992 by Moskowitz, Howell, Goldberg, and Mencken. That's the end, my friend. Just in the nick of time.
My God, you did awesome. My God.
This is like listening to a completely different language, Larry. So appreciative of what you're doing, and it's incredible how on your own you have really jumped so deep into this and trying to figure out all this stuff on your own. It's completely a different language to me. How about you, Javi?
My God, the crazy thing is that yesterday I was reviewing CBCTs to check cases. I'm scared that I'm looking for those S patterns in some point. You know
something? Let me tell you something, Javier. You can't go back too many times to your images because each time you learn something new, it adds another level of diagnostic recognition. And so even in reviewing my cases, and I thank you because this gave me the impetus to do this. In reviewing them, I said, oh my God, what I didn't know and what I think I'm missing. And now when I called James, I got to get him back in. I haven't seen him in almost 10 years. He grew up, he went to college, he was working all overseas. Now he's back in the area. And he said, you can call me anytime. I said, James, I love you and your parents. And this whole thing with him he started to wear his appliance way too much. And almost 24 hours, his bite opened up, which I didn't show you. And I saw this. He came to my house Thanksgiving in 2009 for dessert with his parents. I took one look at him. I said, sit down in the kitchen, dude. And I said, you're in the office this weekend. Okay.
My God, this put a definitely another layer in scanning, in interpretation of images. It's fascinating. Honestly, I seen too many condyles with really weird shapes, but now I'm gonna be looking for those specific things.
And you know what you're doing is so important, because I don't hold all the keys to the locks. We have to unify as a group across the world to be able to put these stories together. I don't have the same things that you will have in your practice, and what they are going to be and what they look like, who knows? But I'm willing to learn. I'm willing to put the time in. My friends,
thank you so much.
I see my favorite Francesca. Hi, enjoy your lecture.
She's almost ready. So we have another winner, another one that he passed this